far from the great equalizer, as the pandemic was foolishly called. On the contrary, the pandemic has turned out to be the great exacerbator. The exacerbator of the pre-existing inequalities within society that have been worsening over the last decade. They've always been around. They've been pre-existing. Our findings showed that Black and Asian ethnic minorities, referred to as BAME, were twice as likely to die of COVID-19. And they are 7 times more likely to live in overcrowded housing. And they are more than twice as likely to be rendered unemployed as a direct impact of the pandemic. Now, these are stark figures and really gloomy statistics. Yet there is hope and there is optimism. As we come out of the COVID crisis, we have been given a unique insight and a unique introspection like never before. We're confronted with this question. It's on the forefront of everyone's minds. On what type of society do we want to build going forward? We really need to reclaim our future. And I believe that is a society that should be focused on building back fairer. We've got a tremendous panel set up to discuss some of these issues and to discuss the decolonisation of medicine and beyond. But before we get started, I would just like to ask you if you could all kindly stay on mute, and there'll be an allotted time at the end for questions. But I know you've been waiting around for some time now, so to kick us off, Gwenetta, can you please talk to us and inform us on your area?
Hello. Thank you. I would just like to say I'm Dr. Gwenetta Curry from the University of Edinburgh. I'm a lecturer of race, ethnicity, and health. I'm originally from the US and I've been in the UK for a little over a year and a half now. And since coming here, over the last year, most of my work has focused on how racial and ethnic minorities in the UK have been disproportionately affected by COVID-19. Today, my presentation will talk about how we could, or some of the history around decolonization and racism in medicine, and leading to some of the data that we know about COVID-19. Okay, yeah, so decolonizing medicine. I'm gonna define what decolonization is. A lot of the time when we talk about decolonization, some people see it simply as the inclusion of racial and ethnic minority writers or scholars and some of the learnings and teaching, but it's more than that. So today we're gonna define what decolonization is and who actually created it, look at the history of racism in medicine, structural racism, and linking structural racism to COVID-19. Decolonization was created by Frantz Fanon, who was a Black Frenchman who analyzed the psychoanalytic problem facing Black people. He resisted the definitions of Blackness given by whites. The colonizer defines the colonized population, but the people or the population already have their own definition. In other terms, we did not need white people to tell us where we were human or not. We already knew we were human. If decolonization is the goal, one must challenge the theoretical framework used to study Black people who have been colonized by Europe. And when you think about this in terms of medicine, we have to adjust the way we teach medicine, because the way it's currently done is students leave medical school with the idea that they're only going to ever treat a white body. And they don't take into consideration the cultural differences or the histories that go along with racial and ethnic minorities. So I'm going to touch on about 3 areas of history that kind of discover or unveil some of the mistreatment of Blacks, starting with the Tuskegee study of untreated syphilis in Negro males in 1932 through 1972. Although penicillin, which was an effective medicine, was discovered in 1947, Black men did not receive the treatment. Instead, they were given a placebo and they were left untreated for years, decades even, to die from syphilis, just because the scientists wanted to see what syphilis looked like in the final stages. right? So this type of medical mistreatment has been happening for years. And some people say, well, that was so long ago, that has nothing to do with now. They're people, they're family members that were involved in these studies, or their family members that were involved in these studies that still exist now, still are alive right now. Think about 1972. My parents were born in 1960. So they were alive during this time. So it's not so long ago that we forget these type of atrocities. Henrietta Lacks is another one. So with the HeLa cells, what many people have probably heard of but didn't know the history behind, doctors at Johns Hopkins Hospital in Baltimore, Maryland, took samples of her cancerous cells and found that they had a unique ability to survive. And without her consent or knowledge, they shared it with other scientists. And with the use of her cells, they were able to make medical advances in cancer studies, immunology, as well as infectious disease. And as of lately, it also helped with the development of the COVID-19 vaccine. And the kicker is her family did not receive compensation. And both of these studies really highlight the use of Black bodies in the name of science and medicine without the consent or the consideration of the life that was involved. And the history of gynecology. Many people don't talk about this. And even the term that's currently being used, the Sim specula, they still hold him to high regard. James Marion Sims was an American physician who became known as the father of modern gynecology. He developed his techniques on enslaved Black women without their consent, naturally, but also without the use of pain medicine. And these narratives of Black people not feeling pain is something that's still an issue now. There's research showing that Black patients are less likely to receive pain medicine when they come to the hospital. They're seen as drug seeking if they do ask for pain medicine, or their concerns are largely ignored. Now, these are things that persisted. Now, this happened in 1845. Again, moments in history that affect how we do medicine today. Maternal mortality in the US and the UK, Black women are more likely to die from a pregnancy-related complication than their white counterparts. The Embrace report in 2019, it showed that Black women were 5 times as likely to die than white women, but now it's down to 4 times as likely, which is still a high rate compared to their white counterparts. In the US, the latest CDC data demonstrated that Black women die at a rate that's 2 to 3 times higher than their white counterparts. And in medicine, a lot of people are taught that increasing education or economic status should improve your health or your chances of living a longer life. But for Black women in the US with at least a college degree, they were still 5.2 times as likely to die from a pregnancy-related complication compared to white women with a college degree. And we have to ask ourselves, why do these things happen? Why do Black women with a college degree have such different experience than white women with a college degree? What is it about the value of the Black life that's seen as different from the value of white life? And I always bring in the example of Serena Williams. The Serena Williams is a millionaire. Yet when she was in the hospital after having her baby, she told the nurses that she felt ill. She thought she had a blood clot because this is something that she suffered from before. So she knew she needed a heparin drip. And when she talked to the nurses, they kind of brushed her off because they're like, well, what does she know about this? Clearly, she just had a baby. She's overreacting, right? Being brushed off. And even she had to advocate for herself. But think about if she wasn't this $1 million Serena Williams, would the nurse listen to her, right? There have been multiple cases that have been in the news in the States that show that Black women's concern are not taken seriously when they're talking to doctors. Dr. Jiva John is a postdoc that worked with me in Usher, and now she's back in practice. She's also OBGYN. She did interviews in the Lothian area for Black and Asian minority ethnic women who were actually pregnant, and they talked about their interactions with the NHS. And here's a quote that demonstrated some of the problems. The patient said, "I saw a doctor who was supposed to explain to me like what's happening because I was very stressed and I was having contractions and I was in pain. So he saw me on Saturday and then he sent me home. On Sunday, again, I went back because I was in pain. I couldn't feel the regular movements. The doctor was there, but he refused to see me. And he just told the midwife to let me know that I should just go home. And he wouldn't see me. So that was not really nice. And it was, yeah, it was a bit, unacceptable. So if you think about, this is in Lothian, this is right here in Scotland. And we have this narrative that racism and discrimination doesn't exist. But when the patients are telling you, this is my experience with the healthcare system, we have to pay attention. And we know that there are issues that definitely need to be addressed. And we talk about this history of racial stereotypes as a source of racial bias, all right? The stereotype is a preconceived and oversimplified idea of characteristics that typify a person. I like to use this example of a Black man hailing a cab in New York, because the idea that a Black man hailing a cab in New York is almost impossible for them to, no matter what they're dressed as. They can have on a hoodie and jeans, they can have on a suit. It's very challenging for a Black man to get a cab in New York because of the stereotypes that go around with Black men being dangerous, not being willing to pay, being thieves, all the negative stereotypes that go along with it that have been written onto their bodies. So when you take that into the medical realm, physicians deciding on who will get a kidney transplant, on the basis of these stereotypes of Black people, they're seen as less educated and less likely to follow transplant protocol, regardless of education. The survey results showed that physicians perceive their Black patients to be less intelligent, less well-educated, and less likely to have the personal characteristics most conducive to successful rehabilitation for cardiac procedures. So it's something that doesn't, it's not one of those, oh, this is a racist moment, I had to deal with this and then I moved on. This is a life and death situation. Whether you get the kidney transplant, whether you get the heart surgery you need, these type of biases can cost you your life. Systemic racism as defined by Joe Fagan, the complex array of anti-Black practices, the unjust gain, political economic power of whites, the continuing economic and other resource inequalities along racial lines. The white racist ideologies and attitudes created to maintain and rationalize white privilege and power. A lot of people think about racism and they only focus on the overt instances of racism. So are there racial slurs happening? Are they being attacked based on their race? Now, that's not the only form of racism, right? Covert racism is something that is pervasive in society. And when people don't understand that racism has more than one form, they ignore it. Covert racism is denying employment and denying housing loans and limiting admissions to people of color. If we look around to within our institutions, how many Black people are actually in the departments that we're in, right? And we have to ask ourselves why. And when you talk to some of these hiring panels, it's like, oh, well, we just didn't have any qualified candidates that happen to be Black, right? And we have to pick the most qualified candidate. This assumption that Black people are not qualified for these roles is just outrageous, right? And there's something that, again, that has to be accounted for. Now, when it comes in terms of COVID-19, the data has been very clear. Where you work and where you live increases your risk of contracting the virus and also increases your risk of dying from the virus. This is data from ONS, and it shows males and females, Black, African, Bangladeshi, and Black Caribbean had the highest rates of mortality. And this was adjusted for age, geography, right? And if you look across the board, Black African had the highest rate of death of any ethnic group. And we have to understand why that is, because Black people only account for 3% of the population in the UK. If you account for 3.3% of the population, why are you dying at such a higher rate? What are some of the causes? This again shows the mortality rate by deprivation. What we know is that racial and ethnic minorities are overrepresented in the most deprived areas. And what this graph shows you is that the most deprived areas have the higher rates of COVID-19 mortality. So again, where you live impacts your chances of life. Now, where you work. This is another graph from ONS. And if you see on the left, it shows the occupations by ethnicity. And on the right, it shows you the deaths involving COVID-19. And racial and ethnic minorities, Black people, as well as Bangladeshi and Pakistani, are well overrepresented in the taxi and cab drivers and chauffeur jobs, as well as in the food, drink, and tobacco processing operatives, and a number of other service jobs like security guards and related occupations, and care workers and home carers. And what we know are those jobs are the front-facing jobs and people that could not stay at home in the time where things were on lockdown. So again, these are the populations that are overexposed and underprotected. In conclusion, in order to decolonize medicine, there must be a reckoning with the racist history of medicine and a better understanding of how this history impacts our current medical practices. And when we're trying to convince these populations to participate in simple things like vaccine uptake, we have to understand the history of racism and discrimination that they have experienced that may lead to them not wanting to participate. Thank you.
So yeah, I just want to say that was, a really powerful presentation by Gwenetta, and it just highlights the importance of history. History matters, and we just cannot neglect that area. It's unfortunate that we're not taught about these things enough at medical school, and also wider society in the school curriculum. I was listening recently to John Henrik Clarke, the Black historian, and there was an interesting quote he mentioned that Europeans not only colonized most of the world, they colonized information about the world as well. And that's key. And that's key. And, we need to break this cycle. Black history is human history, and we need to understand it in order to really, have a critical eye on ourselves. But no, thank you very much, Gwenetta. I learned an incredible amount there. Fantastic stuff. But the next speaker, so Yvonne, Dr. Mbaki, as many of you will be familiar with, is a lecturer at Nottingham. And without further ado, I'll go straight on to her. Dr. Mbaki, it's all yours.
Hiya, sorry, I just needed to be unmuted. Thanks, Jatinder, so much. And it's my pleasure and privilege to be talking to you this evening. And I'm sort of, I guess, taking the baton from Gwenetta, following her discussion on the history aspect. So by way of an introduction, I'm Yvonne Mbaki, Associate Professor at the University of Nottingham. I teach early years medicine. And so I'll just be talking to you a bit about some work we've done in producing a resource to help colleagues decolonize the medical curriculum. And prior to starting my talk, I just want to acknowledge two colleagues who have been integral in the work that we've done here at Nottingham Medical School, specifically Ellie Todorova, who's the Faculty of Medicine and Health Sciences EDI coordinator, and Pam Hagen, who's the School of Medicine Director of Wellbeing. So in terms of, so my own personal reflection is that with regards to the decolonizing of the curriculum, it sort of came to my radar a couple of years ago. So I'm new to the subject and of decolonizing the curriculum. And basically this was prompted by students who came and approached myself and Pam Hagen, who I'm acknowledging here. And they were all Black, Asian, minority ethnic students, and they were keen to get a working group to aid in terms of helping with having an inclusive learning environment. And so they identified multiple things that they wanted us to sort of champion within Nottingham Medical School. So things such as social activities, making sure they're more inclusive, the welfare of our Black, Asian, and minority ethnic students, the ethnicity attainment gap, but also the education aspect, specifically having more diverse content within our material. And so this dialogue took place in 2017, and we sort of started small steps in terms of trying to address these requests from our students. But I suppose on reflection, most of the work we've done now, including the production of this resource, took place after we signed up, Nottingham Medical School signed up to the BMA Charter, the British Medical Association Charter for medical schools, and that's a commitment to preventing racial harassment, preventing and addressing racial harassment. And so that's where we're coming from. And within the BMA Charter itself, there were 4 areas that were identified, and area 3 within the BMA Charter was ensuring there is an inclusive learning environment. And so within the learning environment, that's where we come to decolonize our medical curriculum. So myself and my colleagues, in consultation with our students, produced this resource that we disseminated to our colleagues here at Nottingham Medical School, but also it is now available online as well. And so in terms of why we need to decolonize the curriculum, for us, certainly, and this is my own reflection, is that the student voice has been very vocal, and they have written open letters to us, but also from our School of Medicine, Black and Minority Ethnic Working Group. They have been very, very vocal about this. And also, we live in a modern society, and Gwenetta has alluded to that. We have a diverse population. The population have diverse healthcare needs, and so our medical students do need to be prepared when they go out into the world. But also from this, because of the knowledge that the Western framework of education we're exposed to, it means we have our own implicit biases. And so we do require our students who are going to be future healthcare professionals to challenge those implicit biases in order to effectively serve their community. And so my sort of definition of decolonizing, and I know Gwenetta has alluded to that, I literally have the same sort of understanding of decolonization. We're requiring to deconstruct and reconstruct knowledge. We are requiring to re-educate ourselves, some of us, but also we do need to create a safe space within the curriculum for inclusion of underrepresented voices. I think that's very important. And as I've already alluded to, we need to challenge our own implicit biases, because we all have a different way in which we view the world. So I think that's quite important in itself. And the process of decolonization, which is something I think, because the narrative is ongoing at the moment in medical schools, I feel we do feel under pressure to decolonize the curriculum. To me, it needs to be a cultural change. It shouldn't be a tick box exercise. And I think there is a temptation that, people are just tweaking material within their curriculum, but it needs to be reflective in nature, because we want to change the way we think. We want to change the learning environment for our students in order to make it more inclusive. So it is a reflective process. I appreciate there are some quick wins when we're approaching decolonizing our medical curriculum, but also the fact that we have to re-educate ourselves. It's not going to happen overnight. So it's very important that we are aware that this sort of process is going to take time, and it's going to be an ongoing process down the line. So within our framework that we produce to guide our colleagues in terms of approaching decolonizing the medical curriculum, Gwenetta has alluded to the history of the subject. So the history of race in medicine. And so we identified the history of the subject as one, thing that is a requirement in terms of educating our medical students. So understanding the history about some of these unethical experiments that were undertaken to advance medicine and science. So Gwenetta has given the examples of the Tuskegee syphilis experiment, study of untreated syphilis, James Marion Sims, who's the father of obs and gynae, Henrietta Lacks. So our students do need to have an awareness of this, and hopefully also from that they can challenge their own implicit biases. So one of the domains within our framework is delivering the history of the subject to our students. Another thing to consider, and this perhaps is the one where there may be more quick wins from this, is adapting the teaching materials. And we're having a discussion before the meeting started about dermatology. That's an area that features significantly. So it's ensuring that when our students go out to the clinic, they are competent to identify various symptoms within the patients they're sort of meeting. So that's why I think, and some of you may be familiar with the second year, I suspect they're third year now, medical student Malone Mukwende produced Mind the Gap as a resource, and that just took a different trajectory, because everyone was in need of such a resource, just to be able to identify various conditions within different skin tones. So the teaching materials are something that people need to sort of think about, ensuring that the mannequins we're using to train our students are of different skin tones. So in Nottingham Medical School, that's something we're actually working on in terms of sourcing, mannequins of different skin tones. Knowledge production is very interesting, because when you think about the knowledge production, predominantly there's the exclusion of the global South. And so we do have to have an integrated way in which we can merge the knowledge produced in the global South to the knowledge produced within the global North. And the current inequalities, which Gwenetta has alluded to, and I actually have this as one of my points, is we need to check ourselves within our departments. Do we have any Black, Asian, minority, ethnic representation within the department? Because they're the ones who are going to be you need to have representation in order to progress the work of decolonizing the curriculum. And also something that comes, or I hear often from our students, is, so I deliver in a STEM subject, so I'm one of very few Black female academics in my school. And whenever I talk to students, they are like, we need to have role models to inspire us as well. So just to summarize, in terms of our framework that we came up with, we identified 4 domains, and those were primarily focusing on the history of the subject, knowledge production, and ensuring we're inclusive within our research practices, a focus on current inequalities, as well as adjusting the teaching materials. So thanks so much for listening.
I mean, excellent stuff. It was fascinating to hear that, and really encouraging as well at the same time, to hear that this is a student-led initiative. It was students that really pushed the medical school, and to mobilize students is a difficult thing. We see it in politics all the time. We don't vote, we don't get involved very much, but to see this being student-led just shows how the events of the past year, and even beyond the past year before that, have really shaken people and really taken hold. And so it's fantastic to see that the medical professionals of the future and the academics of the future, the scientists of the future, are so aware of the social injustices going on. And the population now, we're so multicultural. You have people from all corners of the world. We're increasingly globalized, and the medical curriculum has to reflect the population it is going to serve. Otherwise, it's pointless. We'll be serving a fraction of the population. The other thing I'd just like to reiterate, as Dr. Mbaki very expertly said, is the cultural change. So I remember when the Doreen Lawrence review came out, it was either earlier this year or late last year, a big implementation, a big change was the cultural shift that is needed. And that comes through education. That's the essence of it. So fantastic to hear that, and very encouraging as well. So the next speaker is Megan, and Megan is a clinician and a doctor working in Birmingham. She may want to further introduce herself, but I'm looking forward to what she has to say. So over to you, Megan.
Great. Yeah, thank you for having me. And it's been really interesting hearing the speakers so far. I'm really looking forward to the discussion as well. And I guess I'm particularly pleased to kind of join on the title of this event, because I feel that, yeah, it's essential that we kind of continue to explore and learn about decolonisation. But I also think that it's kind of essential that we turn what we learn into action, and that we play an active role as individuals and as a society in addressing colonisation and working to tackle the morbidity and mortality that it results in. But I kind of feel, and I guess maybe some of you might be feeling, that it's not really a very straightforward task to kind of achieve a decolonised understanding of health. And so I wanted to kind of focus more on kind of what we can do to move towards that understanding, as I kind of feel that it's in the process of decolonising health that we'll be able to better understand and achieve it. And I guess firstly, kind of like the other speakers, I just wanted to kind of make clear my perception of colonialism in health. And for me, I think the most relevant aspect of colonisation is the mindset that kind of your views and your ways are superior to others, and then the resultant impact of this, so that you feel that you have a duty, the need and the right to spread your ideas and your ways and to impose them on others. So then I guess using the term decolonising health, I'm referring to kind of removal of these remnants of colonialism that kind of continue to impact how we conceptualise and how we explore and how we address health today. So kind of removing the colonial ways of seeing and knowing every aspect of our society. So kind of race, gender, sexuality, disability, spirituality, on kind of what is of value and what isn't, and who is of value and who isn't, and who is the norm and who isn't. So I guess I just wanted to talk about a couple of things, just kind of briefly to reflect on the impact of colonisation in health that I've witnessed as a doctor, and then to reflect on some of the obstacles to decolonising health that I've come across within myself and the healthcare environment, and how these obstacles can be overcome. So regarding the colonisation of health that I've noticed whilst working as a doctor, I just wanted to give a couple of examples. So regarding colonial views of what and who is of value, and whose ways of knowing and being count. So regarding what is of value, I think the most obvious way that this appears in medicine is the idea that there are facts about health waiting in nature to be discovered, and that the superior way of discovering these facts is through contemporary Western ways of knowing. And I can remember kind of having an understanding during my undergraduate foundation training that in medicine, there were facts that somebody had discovered and that I needed to learn. And that if I learnt these and was able to gather the facts from my patients and then provide my patients with my analysis of these facts, then I'd be a good doctor. And from my kind of student selected components and individual tutors, or from kind of sources outside of university, I did continue to receive the message that health was dependent on wider societal issues, but that there were wider issues that impacted on the prevalence of health and disease, but not the kind of wider society itself can shape the nature of health and disease itself. And I don't think I really kind of gained the ability or the language to explore this until the conversations I had when I worked in Australia, and the kind of reading that I did whilst I was doing my master's, and then the talks that I went to whilst I was in London. I think my most vivid memory of becoming aware of this was when I asked one of my Aboriginal patients what health meant to them, and their answer was being on country, so being on and caring for the ancestral land for which they were the traditional owners, and that not being on country was unhealthy. And I can remember thinking that in my eyes, we remove people from country to make them healthy and then return better able to enjoy life. But in his eyes, the removal from country was what made people unhealthy, and that this process would cause lasting damage to health, despite improved scores on the health measurements that I had. So kind of between the two of us, our different ways of seeing would impact how we conceptualize, how we explore, and how we address disease. And so we'd likely come to kind of quite different outcomes and different knowledge when exploring the same broad area. And so I kind of ended up thinking that if we could differ so greatly on what health is, and if my treatments were valid for my view of health, then was my practice valid for this patient? And if not, was I actively doing harm despite being well-intentioned? And I guess whilst the kind of contrast in our ways of seeing here made me aware of this issue, the query as to the validity of my knowledge and practice ended up paralysing me in kind of various situations after this, whether it was kind of being on nights and being unsure of the influence of the dominant ways of seeing on the knowledge that I have about the best practice for management of patients with emotionally unstable personality disorders, or the validity of assessing the suicide risk in relation to patients who are often left out of research, such as the Gypsy, Roma and Traveller community. And I think I'd been broadly aware of the limitations of my Western education, kind of academic and societal. And I was aware of the need to decolonize our medical curriculum. And I was aware of institutional racism, classism, heteronormativity, and so on. But I lacked a kind of deeper, more nuanced understanding of neocolonial powers, particularly the role that I might play in perpetuating them, despite being well-intentioned and trying to be aware of my impact. And I'd overestimated my individuality regarding this, kind of somehow feeling that because I didn't agree with colonialism, I was to a degree able to act outside of it, and being unable to see that my thoughts and actions, much of them were of it. And I guess I was aware that patients brought their histories to me to explore, and that their interaction with me may be influenced by their interactions with previous clinicians, but not that I bring a history to the interaction, and that for many, the history that I bring is a history of drapetomania, dysthesia aethiopica, unethical and barbaric medical experimentation that has been mentioned already. And that kind of my way of seeing and knowing medicine and health isn't outside of colonialism, and I don't act within a vacuum. So as I act within society, what may seem as a kind of inconsequential position or a small mistake to me works to reaffirm or perpetuate colonialism in myself and those around me. And then I guess kind of also, without having a conscious awareness of the history that I as a doctor bring to my patient interactions, I was unable to recognize references to this history and unable to adequately allay my patients' concerns regarding it. So I found this particularly difficult, as I'd known that I wanted to work in addressing structural determinants of health kind of in the long run, but I'd been happy that I could still do good on an individual level until then. But I think kind of losing faith in the evidence that guides my practice left me feeling pretty uncertain of my ability to do this. And looking at the kind of scale of the task to address it, I couldn't really see things changing, or at least not quickly enough. And so here I find Kingma's description of social constructivism particularly helpful, and the idea that something is at least in parts the product of social processes, and that the same issue thought of at a different time or by different people may produce different answers. So the current reality is not inevitable and it's not immutable. It's a constant changing reality, and it changes as a result of the interaction of individuals with each other and with their world, and through the creation of new knowledge. And therefore, we have the power to shape this reality. And as critical discourse analysts say, academic practice should be based on the knowledge that one's theories, descriptions, and explanations are not value-free, and are instead within and therefore influenced by the socio-political environment. And as healthcare workers, we often create and perpetuate knowledge through educating patients and the public, or educating our peers and juniors, or through audits and quality improvement projects and other research projects. And when doing this, we therefore have a duty to recognize and respond to the influence of society on our perception of reality, and the influence of our knowledge on society's perception of reality, and kind of in turn on reality itself. So then moving on to who is of value, looking at my undergraduate and my continuing medical education, ideas around whose knowledge is of value are never explicitly said, and then are never kind of explicitly questioned, but they were constantly reaffirmed, from whose voices were left out of my curriculum to the language used when their voices were discussed. And again, I don't think that I was aware of the language to verbalize my discomfort with this, or that there was kind of an actual practice of discourse analysis until I did my master's. But I also think that the discourses that we create and perpetuate around whose voice is of value in health don't just impact healthcare workers and trainees, because I can recall countless instances when a patient said to me that modern medicine, particularly psychiatry, isn't theirs, it isn't for them, and it isn't by people like them. And I can see, kind of just going off some past kind of exam questions, the content of the curriculum, the lack of perspectives that aren't from kind of straight, white, middle-class people, you can see where this comes from. But kind of health and medicine and health knowledge are not contemporary Western creations, and we can't have a monopoly on them. And I think particularly like Gwenetta had Frantz Fanon, he's kind of my idol as a psychiatrist and a psychotherapist. So I guess here then I find Ryman and Fairclough's description of discourse is particularly helpful in kind of reflecting on the impact that they have on our perception of health. They say that discourses produce the social world, and different discourses produce different versions of this world. So kind of discourse is socially constructive. But discourses aren't outside of the socio-political environment, and through reflecting and reproducing social processes and structures, discourses are themselves socially constructed. So our society kind of impacts the medical discourses that we create, and then the discourses that we create impact our society. And then in addition to this, Lera Boroditsky says that language doesn't just shape discourse and society, but shapes individual thinking, especially with regards to perception and analysis. So the language that we use expands or inhibits our ability to perceive and analyze and to comprehend ways of knowing health. So kind of for me, with this in mind, one of the quick things that I think that we can all do as creators and perpetuators of knowledge is to review the discourses that we create and perpetuate, particularly through the language that we frequently use in medicine. Language used to kind of classify and divide people and countries that restricts how we then perceive these people and countries, and as a result restricts how we perceive and value their knowledge. So I guess kind of having reflected on the barriers in my mind in kind of our ways of thinking, I wanted to move on to what I see as maybe one of the greatest barriers in the medical profession to this work. And to me, that's fragility. And I've seen this term kind of often used when referring to the fragility of whiteness in addressing racism. But kind of as Victor Lee Lewis says, this description can often be used to describe any kind of human fragility in the face of something that portrays us in a way that we wouldn't like to see ourselves, particularly if it kind of contradicts a self-perception to which we've attached our sense of self and self-worth. So as many go into medicine to help and see themselves and then kind of are seen by others in this way, to see oneself as doing damage despite being well-intentioned and to have uncertainty around whether one is doing damage or not is understandably going to be resisted. So to me, it's kind of more helpful to frame the issue as one of how society instills colonial ways of being within us. And whilst it's not our fault, we will perpetuate its harms. And we therefore have a duty, once these harms have been made clear to us, to address colonialism itself. So I'm not sure how I'm doing for time. I should have looked at the time.
I was going to say, Meg, I don't want to be too prescriptive with the timing. So, you know, however long you want to take, it is absolutely fine.
Okay, I'll carry on. So I guess then also though, making these harms kind of clear to colleagues isn't really an easy feat. And I found that in becoming a medical student and then a doctor, I entered a world that was pretty different to the one that was filled with kind of diversity, collaboration and awareness or lived experience of social inequity that I'd kind of previously inhabited. And it's kind of the medical world, a world where to discuss things that for me had been kind of commonplace since primary school was controversial or political or sensitive. And it was kind of rude to call anyone into discussion on the impact of their normative assumptions, especially if there was any sense that these assumptions were connected to racism. But I also think that this is kind of a dichotomous world where you're kind of having a constant reminder of the violence of the remnants of colonialism and also of the kind of reproductions of it through the contrast in the lives of patients who are kind of UK racialized minorities and those who aren't. And it's kind of a dichotomous world where we're frequently reminded of our duties to kind of remember that we remain a member of society with special obligations to all fellow human beings, those of sound mind and body, as well as the infirm, when we kind of sign up to the Hippocratic Oath, or when we take our kind of duties as a doctor to take prompt action if we think that patient safety, dignity or comfort is being compromised, and also to protect and promote the health of patients and the public. So for me, I feel that we kind of have a mandate to address colonialism. And then that just brings me to the last thing that I wanted to talk about, which is, I think, kind of maybe the most useful thing I found in kind of the practical measures that we can take. And I think there's a lot of opportunity and desire for change coming from medicine, like locally, nationally and internationally, to decolonize the curriculum and decolonize health. But I think that kind of the most help that I found is being part of groups, say national groups, but also local groups, where you can get the kind of support, you can get the ongoing motivation that you need, because I feel that already you can see kind of the windows closing after all the conversations that were started up after kind of the aftermath of George Floyd's murder. And I think it's the times when things are quieter that you need the people around you who you know are kind of also interested in this, but also who will pull you up if you do, or when you do make mistakes in this area, so that you can constantly keep learning and keep kind of rejuvenating yourself. So I guess then lastly, just through, I think, true widening participation, so not just kind of based on race and class, but on life experiences and ways of seeing and knowing, I think that I hope that we could find preferential ways of seeing and knowing some of the aspects of health that may be difficult or limited at present. And so I think the kind of uncertainty of beneficence and validity of our practice might raise discomfort within ourselves. A loss of certainty also raises opportunity for more open discussion on a more even level, and for kind of novel preferential ways of conceptualizing, exploring and addressing health. And so to me, decolonizing health offers opportunity, not just to those who are currently not involved in discussions on health out of a matter of courtesy or kind of out of allowing them to lead the lives that they have reason to value, but I think it also offers opportunity to everybody, because we can all benefit from these different ways of seeing and knowing and different ways of being. Yeah, I'd be interested to hear what people's thoughts are. Thank you.
Well, again, I have to say, fascinating stuff, and incredibly inspirational as well to hear that a medical doctor that's currently working in medical practice, has these fascinating views and, has this level of insight. And I think in medicine, it's never quite easy to understand the margins of your own knowledge, and it certainly, it requires a very critical eye, and I think you managed that incredibly well, Megan. And I just want to say that, being in such a diverse city in Birmingham, I'm not far from there in Wolverhampton, it gives me so much hope that, your patients are getting the very best experience. And also, just want to pick up on one thing that I just want to reiterate, is that you mentioned medicine is not a vacuum, and I totally and utterly agree with that. I think any attempt to insulate medicine or insulate yourself as a doctor from the socio-political context, from the social determinants of health, is almost like a derelict of duty. You're missing out such a big chunk of clinical care by insulating yourself, and that can never be right. But absolutely fascinating, and certainly a lot of lessons to be taken away with. So thank you very much for that.